Good. Okay, thanks. So my talk is on we know is mitral valve repair or replacement or any surgery for the mitral valve in the presence of ischemic mitral regurgitation, is it useful or not? That's the topic I'm given. So good thing is I thought I was going to speak second, so I was about to cancel off a lot of my slides because the previous speaker to me was supposed to teach what ischemic mitral regurgitation looked like, but good thing is I didn't. So let's just do that. Often for CABG, I don't know your practice, but in my practice, I often put in TE. In fact, I routinely put in a TE even for CABG. So you will say, what is the justification? The valve's normal. I will then say, well, I put in a TE for a lot of reasons. I help to see if there's aortic regurgitation, so that I can tell my surgeons, is it good for antegrade or retrograde cardioplegia? And at least a few times we have noticed, well, this thing is quite a lot. Maybe you should think of a retrograde. If the surgeon doesn't believe, when he gives the antegrade cardioplegia, the whole heart swells up, LA swells up. I said, well, okay, take this just as a friendly conversation. Next time, maybe you should think seriously of retrograde cardioplegia. If we tell you there's quite a significant sort of aortic regurgitation that's not picked up prior because it's a CABG. So anyway, I routinely put in echo, so I get to spot a lot of interesting things. Very often we'll get one of these. Often they're not for CABG, even not in a bad heart, not in a poor EF, in a diastolic dysfunction with EF of 63-64%. We get this image. Will you repair? Will you tell the surgeons, well, do you think we should go and bother with the mitral regurgitation? Or what about this? We see this often as well. So sometimes the surgeon will list for CABG with mitral repair, annulus repair, or annuloplasty. If there's no frail, maybe you think about it. But in this situation, you might see it. If you put enough TE into all the CABGs, you will see one of these situations. So what is ischemic mitral regurgitation? And the learning objective would include what are the indications of mitral valve repair, replacement, or surgery in IMR? And is adding mitral valve repair to CABG useful to the patient at all? What about for severe and moderate IMR? If yes, is it a repair or replacement? So I have a surgeon with us today, so I will defer a lot of the opinion to discussions, because what I learn through what I observe in my field, what my surgeons do. One of our chief surgeons there, Choi Yao Ling, so he's quite a popular chap in the repair world. So mitral valve, just a quick revision. The mitral annulus is not plain. It's mentioned yesterday, it's not planar, but if you look at the bottom left-hand corner, it has got a saddle shape. It's always described as a saddle shape, and in fact, it's so saddle that you have seen this before in the supermarket. It's a set of potato chips. I don't know if you have Pringles here, but this is what Pringles is. Okay, so this is the mitral valve taken from top end down view, so it's a 3D view. And just to introduce you again, so those who are learners, anterior leaflet, posterior leaflet. Posterior leaflet is about a third of the whole length, and anterior leaflet is approximately about 2/3 of the whole length. And then you have learned yesterday the Carpentier has divided this into from left to right, and this is how the surgeons look at the mitral valve as they operate. They twist the whole left side towards themselves, and as it presents from left to right, A1, A2, A3, left to right, P1, P2, P3, left to right. So what they see is your nomenclature. And then there's a C1 and C2, which is a commissural little leaflet at the mouth of the fish mouth. Okay, because of that. And then what we then have is anterolateral papillary muscle is oriented to that portion, and posterior medial papillary muscle is oriented to that portion, and they all share chordae tendineae to the two leaflets, but in a very non-intuitive way. There is not anterior to anterior, but it's actually anterolateral sharing, supplying chordae tendineae to half of A1, A2, and all the way M1, P1 and half of P2. And from posterior medial, they share chordae up to P2 line and A2 line and backwards. Okay, so this is how they collaborate in the heart. So you know from yesterday's conversation, we know that LAD and circumflex supply anterolateral papillary muscles is richer, and only the right coronary artery supplies the posterior medial. Therefore, it's a weaker and more vulnerable. Any infarction, ischemia, the posterior medial papillary muscles get into trouble. Ischemia, it may even break off, rupture off, and then you get a flail chordae. So this is just to look at how the movement and to look at the coaptation line. I've drawn that over. And I'm showing you, if you look carefully, every contraction, systole, 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 whatever happens during systole, the annular plane moves apart. It's very interesting. So this from diastole, it moves this way, but from systole, the posterior annulus moves a little bit away. Alright? So, and I'm going to take you through the leaflet and a subvalvular apparatus. So we have an anterior leaflet, posterior leaflet. Anterior leaflet looks longer at the A2, P2 level. And I'm going to show you the papillary muscles. Generally you represent this at the lateral ventricular wall. And there are three order chordae tendineae. First order goes to the tip of the leaflet, holds it down, the parachute that holds it down. Second order is the one just behind. These are usually the ones that surgeons use to chordae transfer. And then we have a third order, which is from the lateral wall and only exists, it was mentioned yesterday, only exists for the posterior leaflet to hold it down. And this is quite an important mechanism. So do remember this diagram, because as you progress down this whole disease process, if you remember this diagram, you may understand some of the pathogenesis and some of the reasons that will develop later throughout the lecture that I'm going to mention. So this is a plain view. We have seen this a couple of times yesterday. And to label for you, this is the posterior leaflet, and anterior leaflet is right in the center. So ischemic mitral regurgitation really is called a functional regurgitation because the sorry. Oh, it's okay, thanks. Yeah, I wouldn't mind a pointer. So ischemic mitral regurgitation really is a functional mitral regurgitation, meaning that the leaflet itself is not at fault. The leaflet itself is not thick. In fact, it's a very thin leaflet. On an echo image, you'll see not more than 1 or 1 and something mm. It's thin, but yet there's a leak. Okay, so it's not the same. Not the same as the rheumatic heart, degenerative heart that you see, where it's thick, clumsy, bullows, that sort of. So it's secondary to the effect of coronary artery disease. So that is an important concept in ischemic mitral regurgitation. It's not the leaflet at fault, but it's actually the heart at fault. Okay, so this paper shows that heart failure and death after myocardial infarction in the community. And it shows that, oops, something went off. Something went off. Something went off. Okay, so I want to tell you is that after myocardial infarction, more than 50% of the patients develop mitral regurgitation. Okay, so that is one thing. And the people with mitral regurgitation, if they persist having mitral regurgitation, they generally fare with rupture of the papillary muscle, breaking of the chordae tendineae, and then flail leaflet. And what happens is an acute mitral regurgitation after an AMI. What if in the acute mitral regurgitation, the heart, the LA, the pulmonary system has no way of compensating, so they end up with pulmonary edema. And so this way of the treatment is, of course, is acute, emergency therapy, is dilatory, and surgery. Right? That's acute myocardial infarction. Okay, so for chronic myocardial infarction, it has got another story. Wait till the diagram comes out, I'll show you. So what happens in chronic ischemic heart disease? The heart compensates, the wall undergoes remodeling. Remodeling is when the sarcomere changes, they multiply either lengthwise or depthwise. So in the end, it goes out. And if it's poor function, we call it, thanks. If it's poor function, we'll call it regional motion abnormality, right? When you look at the echo, you say, well, there's regional abnormality. Because that portion is not going to contract well. Okay, just let me go to where we just left off. Okay, so this is a rupture which I showed you about, and this is how in acute MI we get ischemic mitral, which we need surgery. Okay, and if we have a flail, in a Carpentier's classification, we'll say it's a class 2 type because there's a flail and there's excessive movement of the leaflet. So I was just about to say that in the chronic mitral regurgitation, there's a leftward movement or lateral movement of the lateral wall. What happens is now there's also decrease in contractility. So it doesn't contract well, and then the lateral wall moves, pulling along the anterolateral papillary muscles as well. And then what do you get? You get stretching papillary muscles. The distance between the papillary muscles move further and further apart. So the lateral wall moves further apart, bringing the chordae tendineae, which is like a kite. If you fly a kite, you know, you pull a string. You pull it further apart and disallow it to go back up to coax. So there is a problem here, okay? So then gradually this stretches. So you have annular dilation. What happens now is that you get to see this restriction here. Which, am I showing it on my screen? No. Did I just pocket your feet? Sorry. This portion here, okay, is where the restrictive portion on the leaflet is. That is a secondary cord that's pulling it down. The primary cord is doing its business, but the secondary cord is pulling it down. So again, if you look at your echo, you get to see this little sign, and some people call that a seagull sign, right? And it's actually due to a secondary cord holding it down. And we call that tethering, pulling it, restricting it from moving freely. So it doesn't go nicely up again, nicely up again. It goes, oh, I can't go up, I can't go up. Okay, so you get this. So if we have a restrictive movement, now here comes Carpentier 3B, where it's restricted and not moving. Okay, so I just want to show you that in the mechanism of a leak in a chronic IMR, the posterior annulus is the one that's really moving further and further back. You know why? Because the anterior leaflet has got a skeleton, it's got a fibroelastic skeleton next to the aorta. It's sharing the same wall, it just doesn't move. It is a back wall that's all muscular, so it's able to stretch. So here comes a problem. The regurgitation comes through all the little gaps because there are not enough coaptation, so there are little gaps in between the scallops, and so we lose my screen again. And so the next thing is, let me continue while he figures that out. So ischemic mitral regurgitation really has got two components. One is the tethering. Tethering is disallowing the leaflets from closing. The other thing is the poor contractility of heart. It's not really contracting well, and therefore it also doesn't do with this sort of degree of deceleration time. Then generally the survival rate is also a little bit poorer than those who have a longer DT ratio. DT time, sorry. Okay, thank you. You might have to stand there. Okay, so tethering force comes back to if there is annular dilation, there's central jet. He's going to do that. He's the tethering force, correct. Thank you very much. So with the tethering force, this annular dilatation, what happens is centrally you're not going to coax. So we get a central jet. Okay, so that's type 1. So then if the papillary muscles get displaced, you get pulling down of the chordae and restricting it from moving, then we get a type 3B. So now, this is ischemic mitral. Look at the leaflet. Leaflet's normal, very thin. If you were to measure it, it's about like 1 point something mm, 1 mm. So one look and you know is not primary problem. The primary problem is subvalvular. Anything below that's causing it to happen. Okay. Of course, then if it's a central jet, one jet, you can do PISA, you can do vena contracta. But if it's a multiple jet, like the picture I showed you earlier where the valve closed and all the little holes are leaking, then, and also if there's a lengthwise leak, then you're not going to be able to calculate this PISA or the vena contracta meaningfully, and we heard it yesterday. Do you add all? Nobody knows. So what we do now in terms of that is we look at how much in total is a regurgitation. What goes through mitral valve, what goes up through atrial valve, the balance has gone back through mitral valve. Simple arithmetic. And so then the new classification looks at the ERO at 40.40 cm, 40 mm squared. Okay, and whether the regurgitation volume is revised already. Is revised up to 60 mils, and if the regurgitation fraction is more than 50%. Okay, so no more 20 cm, no more 0.20, is now 0.40 cm. This is recent guidelines, and they have divided mitral regurgitation, ischemic mitral, into whether it's asymptomatic or symptomatic or severely symptomatic. Okay, so vena contracta is not measured because there is just so many jets. You cannot be too accurate, right? It's just like somebody was saying yesterday, eyeballing. Sometimes it's eyeballing, but mainly is to calculate the regurgitation fraction, the volume. That's theoretical. And I was telling you that if they have got if a regurgitation volume is more than 30 mils, generally they also don't do so well. If you look at the graph, if you look at the Kaplan-Meier survival curve, the dotted line is the one with more than 30 mils. They generally don't do so well. And this is the one I was telling you about, deceleration time. Those who get discharged from the hospital with a deceleration time of less than 130 milliseconds, they also generally don't survive very well beyond up to a couple of years. Okay, so poorer outcome. Okay, now we come to the meat of the lecture. Is ischemic mitral regurgitation undergoing CABG? Should a mitral valve surgery be included or not? There are many types of mitral valve repair following similar principles. Either you keep the cords, you shrink the sort of distended leaflet and tighten it. Maybe put an annuloplasty to tighten the gap. If you do a mitral replacement, the different types of prosthetic valve, is a bioprosthetic or mechanical, depending on the usage and the preference and the current guidelines. So is mitral valve repair good or not? So pros and cons, I compare it like that for you. Okay, so in moderate or severe recurrent IMR, appears to occur early in majority of patients by 2 years after repair, and more commonly with preoperative LV aneurysm of dyskinesia or motion abnormalities. The higher recurrence of mitral regurgitation and a higher rate of reoperation if we did mitral repair. If we did a mitral replacement, it's durable because the material is tested, is validated, but of course then comes with it a higher, on average, a higher mortality rate across 30 days compared with repair. Now, so surgical treatment for severe ischemic mitral regurgitation significantly improve LV remodeling and LV end systolic index, reduce incidence of recurrent MR, reduce the NOI-HA function, and increase the patient's quality of life. So if we do something for severe mitral regurgitation, patients enjoy the life a little bit better. There's a 1.6% mortality rate for repair. There's approximately 4% rate of mortality for replacement. But in the long term, if you look at 5 years, there is no difference or not much difference in mortality. Why? So the mortality for IMR remains high despite surgical management and is probably related to the underlying process, which is coronary artery disease. And despite repair, mitral regurgitation progresses in many patients and then is associated with poor health. This is a retrospective 20 years. Looking at the top dark line, CABG alone for ischemic mitral. Second line with a dashed line, CABG with mitral surgery of some sort. The grey continuous line is PCI with the coronary arteries. The dotted line right at the bottom is do nothing. That means not do nothing. Do no surgical intervention, but medication. Heart failure medication. So guess what? CABG alone had the best outcome after a long years of tracking. So patients with significant coronary artery disease and mitral or severe, moderate or severe IMR undergoing CABG alone, this demonstrated lowest risk of death. So the guideline 2017 European guidelines says it's indicated, mitral valve surgery of any sort is indicated if the patient undergoes CABG and LVEF is more than 30, so anywhere from moderate and above. Class 1 evidence, that means risk, so that means benefit is 3 arrows more than risk. Consider mitral valve surgery in symptomatic patients if the LVEF is less than 30, with an option for revascularization. So it could be PCI or CABG. It should be considered in patients with LVEF of more than 30% if they remain symptomatic despite a lot of medical therapy. So 2017 guidelines says, this American guidelines, same as before actually. So for severe symptomatic, yes, go for surgery. If it's severe but not symptomatic, or if you look at the lifestyle, it doesn't need to exert that much, you can do his own grocery, does the housework, not going to exert a lot of energy, maybe you can skip the mitral regurgitation. So, American guidelines, reasonable for patients with chronic severe mitral regurgitation who are undergoing CABG or AVR. Yes, class 2 evidence. That means 2 arrows, benefit over risk. It's reasonable to choose a cord-sparing mitral valve repair over downsizing annuloplasty repair if operation is considered for severe symptomatic patients with very high-end New York Heart Association class. To repair or replace may be considered for severe symptomatic, class 3, class 4, persistent symptomatic despite optimal medical therapy. So this is more for better quality of life. Okay, this European guideline says that when revascularization is not indicated, okay, only in this situation, edge-to-edge repair is considered. Edge-to-edge repair is a mitral valve. At the moment, we have a percutaneous mitral valve type of surgery. If patients with less than 30% who remain symptomatic despite optimal medical therapy and have no options for revascularization, surgeons are not going to touch the coronaries, a bad, difficult, diffuse disease, maybe edge-to-edge as one option, and it's a 2B classification. So you know what edge-to-edge is. It's putting in a clip following Alfieri's surgical technique, and this company went on to produce the clip, advised by Alfieri of course, and to put the clip together. Does it work? Yes, it actually brings down the class of mitral regurgitation, the grade of mitral regurgitation. It brings down the class as well, class 4 to very low class. But mitral valve therapy, mitral clip therapy has a repair rate similar to mitral valve repair throughout 1 year, but also increase the risk for replacement or potentially replaceable valve. You know why? Because the mitral clip really grabs the leaflet. Mitral clip, have you been fishing before? You know, you need a reverse hook to catch a fish. A mitral clip has got rows of reverse hooks. So as it catches, it actually hooks it. So the leaflet will stay this way like a parachute down, like a little sandbag holding the mitral leaf down. So if there is tethering and it tears off, finish. This leaflet's finished. If you need, it is a regurgitation, you go back, you look at it, it's all chewed up. No use. So therefore, if they have a regurgitation, it's going to be not simple repair anymore. So patients treated with percutaneous repair of mitral valve more commonly require surgery to treat the residual mitral regurgitation. The failure rate is significant. What about patients with moderate, not severe symptomatic, but moderate? Is there any use? So adding mitral valve repair to CABG improves the classification of the functional class, decrease the grade, reduce the secretion of BNP because the heart is not swollen anymore. You know, BNP, brain natriuretic factor, really is from the left ventricle, is not from the brain. So this is really a reflection of ventricular function dilation. But then morbidity goes up because it's unnecessary, and if you put in some surgery, you add on the risk to the patient. They get arrhythmias and no difference in 30-day mortality, whether you do something or not, to a moderate IM. Okay, so thank you. So after a year, they get look at the difference, whether the two lines meet. CABG alone or plus IMR, the two lines meet after a year. So not much of. So today, what is the AHA guideline says is uncertain. But if you do CABG alone, then people with heart failure symptoms at rest, they will not get better. So in summary, CABG alone or plus mitral valve replacement or repair. The pros, CABG alone. That means you depend on revascularization and then you depend on medication as well. You depend on ACE inhibitors or ARA, you depend on aldosterone blockers to cause the reverse remodeling to happen. What if it doesn't happen? Then you still end up with mitral regurgitation because it didn't happen. Okay, so the continuous coronary artery disease continued. If you add on a mitral valve repair, a couple more slides more, it will improve the functional classification. It will help with reverse remodeling. Reverse remodeling means that if a dilated shape, a thick heart, it goes back down to that shape. That's called reverse remodeling. But if you add on more things, more risks, and no difference in mortality rate, and is not a predictor of long-term survival. So is repair or replacement good? No difference in the remodeling aspect, no difference in the survival at 12 months, but something is longer lasting if you have a ring or you have got a fixture, and also it depends on your surgical comfort. Some of the surgeons, when they're just beginning, they like replacement because it's straightforward, change it, but you have other problems called perivalvular leak. Repair, when we first started, we were like going on off bypass just to get the repair correct and then change. But now we can repair it and it's very fast. Within 90 minutes we are sorted out. So it really depends on the surgical skills. So learning objective, we went through what is ischemic mitral regurgitation. I've explained to you. Nothing wrong with the leaflet. It's all to do with the coronary artery disease and a lateral wall movement. Indications for MVR in IMR, you saw the guidelines. It's only for severe symptomatic patients. And is mitral valve repair to CABG useful? Severe symptomatic is useful, but if you look at a 5-year mortality rate, a survival rate, not much difference. Main thing is to treat the CABG, treat the blood pressure, diet control, cholesterol, diabetes. All these other things are quite important, not just the surgery or the anesthesia or the TEE. Thank you. Thank you.